A very good evening, everyone. Myself, G. Arunagiri from Government. I will be hosting this session today. I wholeheartedly welcome our AATRAL staff faculty, Dr. S. Jagadeesan sir, and our presenter for today's session is Dr. who is Chairman of IMA JDN Tamilnadu. Sir,
Good evening. We have yet another star faculty, Jagadeesan, my good friend, who graduated from Thoothukudi Medical College and now he's professor of medicine at the Medical College. He is astute, teacher, and he loves teaching. So I think let us not stand between the learning and today's program. So we will go on to Dr. Jagadeesan. Over to you, Dr. Jagadeesan. I think you can start.
Sir, am I audible?
Yeah,
sir, you're
Jagdish,
audible,
you
sir.
are audible.
Yeah. Sorry. Some network issues. That's why no response.
Yeah,
Yes, sir.
you can start.
Can I start, sir?
Yes, ma. You can start.
Okay. Good evening, everyone. I will be presenting a case on the abdomen. So Mr. XYZ, a 45-year-old electrician from Tambaram, came with complaints of abdominal distension for 3 weeks and yellowish discoloration of the eyes for 1 week. The patient was apparently normal 3 weeks back, after which he developed abdominal distension for 3 weeks. It was insidious in onset, uniform and progressive in nature. He also had bilateral leg swelling for 1 week from the ankles till the knees. There was no loss of appetite, hematemesis, melena, constipation, and obstipation. He had no complaints of chest pain or breathlessness. He had no complaints of oliguria, facial puffiness, or passage of frothy urine. He also had yellowish discoloration of the eyes for the past 1 week, along with passage of clay-colored stools. There was no itching, fever, and no treatment was taken for the same. As far as the stools were concerned, they are of normal frequency, pale, semi-solid, not associated with pain and passage of blood. There was no abdominal pain, no vomiting, no mass in the abdomen, no fever, no dysphagia or heartburn, no epistaxis or bleeding gums, no loss of weight and appetite, and no history of altered sleep pattern. In his past history, he has no similar episodes in the past. There's no significant history of surgery or any drug intake. No history of tattooing, blood transfusion, sexually transmitted diseases. He has been vaccinated. There's no history of diabetes mellitus, tuberculosis, or systemic hypertension. In his family history, there's no similar history in the family. As for his personal history, he has been an alcoholic for the past 20 years. He consumes whiskey 1/4 every week. His bowel and bladder movements are known to be normal, no history of altered sleep cycle, and he follows a mixed diet. So, summary, a 45-year-old electrician, Mr. XYZ, came with complaints of abdominal distension for 3 weeks and yellowish discoloration of the eyes for 1 week. He has history of passage of clay-colored stools with no signs of cardiac or renal failure. I suspect pathology of the liver, so I'd like to examine the abdomen.
Before going into the examination part, okay, from the history, the patient has got an abdominal distension, so which is for 3 weeks, followed by yellowish discoloration of the eye. So from this, what kind of a differential diagnosis you think from the history?
So for abdominal distension, it can be due to cardiac failure or nephrotic syndrome, any protein losing enteropathy, then malnutrition.
Okay.
It could be due to some allergic reaction which resulted in anasarca.
Okay. So usually in liver disease, patient starts with abdominal distension first or with failure?
Abdominal distension starts first, sir.
Okay. What is ascites precox?
So in ascites precox, there will be abdominal distension without significant edema elsewhere.
Okay. So in which condition do you get that one?
It's seen in chronic constrictive pericarditis and tuberculous peritonitis.
Okay. Okay. Apart from this, do you think any other differential diagnosis, such as an infection?
It could be due to hepatitis, cirrhosis following hepatitis.
Does the hepatitis have abdominal distension?
Not usually, sir.
If so, what do you suspect?
He could have progressed to cirrhosis or hepatocellular carcinoma.
Such a short duration of 3 weeks, does a patient develop hepatocellular carcinoma?
No, sir.
Anything else? So patients with viral hepatitis or any other infection can go for acute fulminant hepatitis.
Okay, sir.
In acute fulminant hepatic failure, such patients can develop worsen like anything and they can have ascites at that time.
Okay, sir.
So remember, infections can progress to acute fulminant hepatic failure. So it will be, the deterioration will be hyperacute.
Okay,
in such
sir.
patients, you develop ascites.
Okay, sir.
So you are, apart from this history, what was the history of presenting illness? Can you just go back to the history of presenting illness? Is it okay for you if I ask questions, or you need to complete everything and then we'll have the discussion?
No, sir, this is fine, sir.
This is fine, right?
Yes, sir.
Okay. So in the history of presenting illness, you actually discussed about this patient has abdominal distension, yellowish discoloration, fine. What about the hematemesis and melena? Does the patient have anything?
No, sir.
No. Okay. Suppose if this patient has, along with hematemesis and melena, what do you think?
So there could be an upper gastrointestinal bleed.
Okay.
So in case of liver pathology, if it's associated with liver pathology, it could be a result of a complication like portal hypertension.
Okay. Okay. Suppose this patient drinks alcohol and is a chronic alcoholic. Now presents with abdominal distension and hematemesis. What do you think with vomiting? Esophageal varices, that is due to portal hypertension. Okay. Apart from, if the patient doesn't have it, yeah. So Deepak Raj, he has told that Mallory Weiss tear is one of the thing which happens because of excessive vomiting and there is a tear.
Okay, sir.
Okay. Okay. What do you think is, apart from this, suppose if this patient has got a problem of a recurrent, a chronic problem like abdominal distension, which is there for a chronicity, what else can be a symptom apart from fatigue? Usually these patients have more amount of fatigue.
Okay, sir.
Okay, he complains of clay-colored stools. What do you think from this clay-colored stool?
So he probably has obstructive jaundice secondary to the liver failure.
Okay. Obstructive jaundice secondary to liver failure.
Yes, sir.
What do you think is the reason for the obstruction?
So there's no passage of conjugated bilirubin into the blood. So the color of the feces is derived from conversion of bilirubin into secondary pigments. The lack of pigments means the stools become clay colored. Okay.
Suppose if you think this is an obstructive jaundice, apart from this, what other symptoms the patient might have?
The patient can present with pruritus.
Yeah, pruritus could be there. Okay. How do you think the appetite will be in patients with liver disease? There is no loss of appetite or weight in this patient. If this patient has a loss of weight and loss of appetite, what do you think?
So it could point towards some kind of malignancy.
Okay, apart from malignancy, anything else?
Tuberculosis.
Yes, tuberculosis. Okay, anything else?
So severe protein energy malnutrition.
Yeah, patients with the chronic liver cell failure might have protein energy malnutrition. Because of this, the patient might have loss of weight and loss of appetite. Okay. Okay. You said there was no family history.
Yes, sir.
What do you think? Suppose if this patient has a family history.
So we could try ruling out diseases like autoimmune hepatitis, then Wilson's
Autoimmune
disease.
hepatitis. Okay, Wilson's disease. Anything else?
Hemochromatosis.
Okay, anything else?
And hepatocellular carcinoma. That is the history of.
Hepatocellular carcinoma. Yeah, someone has given the answer of alpha 1 antitrypsin deficiency. Accepted. Okay. So, why do you think the amount of alcohol is very important here?
So for some people, they might consume like a low amount of alcohol for a long period of time and not develop any diseases. But as the quantity increases, the chance of developing a disease is always higher.
Okay. So the amount of alcohol they take each and every day for a long duration, with what type of alcohol they do consume consistently, is very important in causing cirrhosis. Suppose if this patient is a non-alcoholic patient. Okay. What other important metabolic disease you like to rule out?
So glycogen storage disorders.
Okay.
Metabolic syndrome, which is associated with non-alcoholic steatohepatitis.
Okay, non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. What comorbidities you suspect in that patient? And you throw more light on that. Yeah.
We could have diabetes mellitus.
Yes, diabetes. So concentrate on whether this patient is diabetic or nowadays we see more cases which are non-alcohol related. Lifestyle modifications is very important in such patients like diabetes, obesity, metabolic syndrome, dyslipidemia. So you need to have more questions whether if this patient is a non-alcoholic, rule out such diseases as well. Okay. Okay. So from this history, you think this patient is having an acute problem or a chronic problem?
So this is probably a chronic problem.
Why do you think it is chronic? Just because it's 3 weeks?
No, sir, because the symptoms he's presented with point towards a chronic etiology. It usually takes a long time for all these symptoms to occur.
Okay.
So it might have been a very slow process which progressed to this stage.
Was there any altered sleep pattern in this patient?
No, sir.
No. Okay. Suppose this patient is a vegetarian patient. What do you think? Do you think any other coexisting vitamin deficiency might happen along with alcohol?
Yes, sir. He'll probably have a B12 deficiency and folate also. It's possible he can end up with megaloblastic anemia.
Okay. 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 Okay, then proceed.
Okay, sir. So on examination, consent was obtained and patient was exposed from neck to mid-thigh. On general examination, the patient was conscious, oriented to time, place, and person. He is moderately built and nourished. There was presence of icterus, bilateral pitting pedal edema present from the ankles to the knees. There was no pallor, cyanosis, clubbing, lymphadenopathy.
Okay.
Vital.
Okay. What is the significance of built and nourishment in patients with liver disease?
So, in case of chronic liver disease, the patient will have malnutrition. So the build and nourishment would have been significantly reduced. Apart from that, in tuberculosis, once again, there'll be significant loss of weight.
Most of the patients with decompensated liver disease will have anasarca, right?
Yes, sir.
Then how would you confirm whether this patient has got wasting or not?
So by measuring muscle bulk.
Yeah, muscle bulk. Which muscle will you test for the bulk?
For bulk, we can try the arm and the thighs, and the forearm and the legs.
Okay. Okay. biceps and triceps is fine. Along with the patient will be having temporal wasting. So that will be the very earliest thing. Okay. Okay, this patient doesn't have any clubbing. Suppose this patient has clubbing. What are the abdominal causes for clubbing?
So it could be due to hepatopulmonary syndrome, then hepatocellular carcinoma.
Okay.
Then portal
Usually in
biliary
inflammatory, irritable bowel syndrome, you don't get clubbing. But in inflammatory bowel disease, you do get. Someone has written IBS. You don't get IBS clubbing. You can get in primary biliary cirrhosis, then your viral hepatitis. Viral hepatitis, that is more common in patient with cirrhosis. Okay, accepted. Fine. Suppose you told that it could be hepatopulmonary syndrome. What is the classical symptom a patient might have with hepatopulmonary syndrome?
So in hepatopulmonary syndrome, there'll be presence of hypoxia. So he'll present with cyanosis.
Okay, what is orthodeoxia?
So there'll be a pulmonary AV shunt formed. And as a result, there'll be mixed blood passing through the systemic circulation.
Now, what is orthodeoxia?
So there'll be reduced oxygenation with respect to the posture.
Yeah, change in the saturation with respect to the posture. Okay, that is a classical feature of hepatopulmonary syndrome. Suppose this patient develops pallor, what do you think?
So in case of pallor, we'll have to rule out anemia. So anemia could be due to iron deficiency or it could be megaloblastic. Apart from that, the pallor can also be due to liver cell failure or chronic anemia due to chronic disease. Okay,
cirrhosis patient, any patient with liver disease, if they have pallor, first you need to rule out whether there is any upper GIP.
Okay, sir.
Because of port light. See, most of the patient might have a concealed hemorrhage or a melena.
Okay, sir.
So that is one of most important thing you need to rule out. Second is you need to rule out whether the patient is going in for a hepatocellular carcinoma.
Okay, sir.
Along with that, you said that vitamin B12 deficiency, malabsorption, then those megaloblastic anemia is accepted. Okay, what is the importance of checking lymph nodes in patients?
So, lymph nodes can be due to metastasis following some malignancy in the liver, such as hepatocellular carcinoma.
Hepatocellular carcinoma, anything else?
Or it could be secondary metastasis to the liver from surrounding lymph nodes.
Anything else?
So tuberculosis.
Tuberculosis. Don't forget tuberculosis. Because TB can have a varied in terms of symptoms, which can, if it is a disseminated tuberculosis, patient might have hepatosplenomegaly, patient can have ascites, patient can have lymph nodes. So always check for, in your general examination, see, whenever you just get abdomen is the most easiest system to get a pass. Abdomen is the most easiest system to get full marks. Abdomen is the most easiest system to fail also. So the most important thing is you concentrate more on the inspection and the observation. You observe the patient. How is the patient? How is he looking? Each and everything is important for that patient. Okay. So even in lymph node examination, check for cervical area and also check for axillary area. Okay, proceed.
So the vitals were checked. Temperature is 98.6 degree Fahrenheit. The blood pressure is 130/80 mmHg, measured in the right upper arm in the sitting position. The pulse is measured to be 80 per minute, normal rate, rhythm, volume, no specific character. Condition of the vessel wall is normal. All peripheral pulses are felt equally on both sides. There is no radioradial or radiofemoral delay. The respiratory rate is 16 breaths per minute. Then signs of liver cell failure. So in the head and neck, the alopecia, loss of facial hair, icterus, parotid enlargement, and fetor hepaticus were present. No Bitot spots, xanthelasma, subconjunctival hemorrhage, pallor.
Okay, yes, doctor. Suppose this patient you doesn't have history taking. You just go in for a general examination and your physical examination.
Yes, sir.
What do you think is the salient feature to tell this patient is an alcoholic causing liver disease?
So in case of alcoholic liver disease, there'll be parotid enlargement.
Okay, why is the alcohol causing parotid enlargement?
So there'll be autonomic dysfunction. So there'll be
anything else?
I don't know, so.
Okay, most of the patient who is chronic alcoholic will have poor oral hygiene.
Okay, sir.
Because of that, there could be calculi causing perotitis.
Okay, sir.
So along with autoimmune, this is also possible, and there will be excessive fatty infiltration.
Okay, sir.
Okay, apart from this parotid enlargement, what is the feature to tell? This is alcohol-induced alcoholic liver disease.
So he can also have Dupuytren contractures.
Yeah, two most important things. One is Dupuytren's contracture, another is your parotid enlargement. Both tells it is because of your alcoholism. What is the pathogenesis behind feta hepaticus?
So in feta hepaticus, there's production of dimethyl sulfide, and that is responsible for the characteristic odor arising from the mouth.
Okay, okay, fine. Is this KF ring is visible to your naked eye?
No, sir, we have to examine it under special light, but I'm not sure what the name of the light is.
Okay, does anyone? Slit lamp examination. Where is that KF ring is there? In which area?
So Descemet's membrane.
Yeah, it's in the Descemet's membrane. Usually it is visible through your slit lamp examination, but at times it can be visible nakedly. What is the reason for your Bittard spot?
So Bittard spots are due to vitamin A deficiency.
Okay, why is that vitamin A is deficient?
So vitamin A is it's a fat-soluble vitamin, and it's dependent on the production of bile for absorption. So in case of liver cell failure, the bile synthesis is also inhibited. So there's a deficiency of vitamin A as well.
Okay, okay. Okay, apart from this, what is the other signs that is positive in this patient? Liver cell failure signs.
So he also has spider nevi, loss of pectoral and axillary.
Can you tell me what is the reason for spider nevi?
So there is dilatation of the arterioles.
Okay.
So there's a central arteriole and multiple vessels which branch out from it. So it's seen in the necklace area above the nipples.
Yeah. Whenever you describe a spider nevi, it's a dilatation of the central arteriole with peripheral spreading. Whenever whether it will blanch or it will not blanch.
So it will blanch on application of pressure.
Yeah, that is the most important thing. Why it is seen in the neck area? Neck trunk. Is there any specific area for that?
Yes, sir. Above the nipples and the area supplied by
SPC territory.
Yes, sir.
So why it is? What is the pathogenesis behind that?
So it's due to hyperestrogenism.
Apart from spider nevi, what other things can be because of hyperestrogen?
So there's loss of pectoral axillary hair and alopecia. Then there is also testicular atrophy, gynecomastia.
Anything in the hands? Anything in the hands?
So palmar erythema.
Okay, fine. Palmar erythema. So these all things are due to, why is there hyperestrogenemia?
So the liver is also responsible for clearing androstenedione. In case of liver cell failure, all the excess androstenedione gets converted into estrogen, and we end up with all these hyperestrogenic symptoms. Okay,
fine. Was there any asterisks for this patient?
No, sir.
Okay. If asterisk is present, what do you think?
So it could, it probably signifies the presence of hepatic encephalopathy.
Okay. This asterisk can be positive in any other condition?
Yes, sir. It's also seen in lesions of the thalamus, the corona radiata, primary motor cortex, cerebellum, the medulla, and the pons.
See, if a patient has got asterisks, three important differential diagnoses you need to keep it in your mind. Okay, one is hepatic encephalopathy, another is uremic encephalopathy, third is respiratory failure.
Okay, sir.
These things has to be there. Okay, if a patient has asterisks secondary, due to hepatic encephalopathy, what is the next thing you can do from the patient? What is constructional apraxia?
I'm not sure, sir.
Okay, any other volunteers for constructional apraxia?
The patient cannot do the voluntary, who know the voluntary motor activities.
Okay, good. Then how do you check with the patient?
We have to ask to draw a 5-star stars.
Okay.
And numbering, we have to ask, we have to put a number and we have to ask them to connect the number.
Very good, very good. Or else you can just draw a clock and just tell them to put the bigger needle towards 1 and a smaller needle towards 3 like that. So if they won't be able to do that, or just mark few points, ask them to just connect those dots. They won't be able to do that. Okay, fine. Okay, doctor, proceed.
So,
Now, one more question. What are the other conditions where you can get a spider nail? Yeah, pregnancy, few percentage, usually around 1 to 2% you can get in pregnancy. Even 1 to 2%, can you get it in normal individuals?
Yes, sir. 2% of the population
Yes.
will have
Okay.
spider nevi.
Anything else? Anything else?
So thyrotoxicosis. Okay.
Anything else? You can get in viral hepatitis. At certain conditions, you can get primary biliary cirrhosis also.
Okay, sir.
So remember, viral hepatitis, pregnancy, even in normal individual, thyrotoxicosis, you can get it. Apart from this, is there any other skin lesions will you expect in a patient with cirrhosis?
So they can have purpura.
Purpura, okay, accepted. What do you think is the reason for the purpura?
So it's a result of bleeding manifestations. The
Okay,
clotting factor.
You can get it in coagulopathy. Apart from this, anything else?
So if the person has obstructive jaundice, there can be pruritic marks over the abdomen.
Okay, accepted. Anything? Any other petechiae? Why do you get a petechiae apart from coagulopathy? Any other reason to get petechiae?
So if the patient has dengue, there will be petechiae.
No. I'm not asking about co-infections. I'm just asking about cirrhosis. See, DIC, high dysfibrinogenemia, everything is because of coagulopathy.
Okay,
See,
sir.
most of the patients with cirrhosis, if you check their platelets, they will be having thrombocytopenia. Why?
Yes. So there can also be splenomegaly.
Because of splenomegaly, there will be immune thrombocytopenia.
Okay, sir.
Because of the immune thrombocytopenia, most of the patients might have petechiae. So if a patient has coagulopathy, you think petechiae can be a reason. If petechiae, coagulopathy, then your immune thrombocytopenia. Apart from this, any other skin lesion?
So caput medusae.
Caput medusae, it is seen in the umbilicus. I'm asking about skin lesions.
Okay, sir.
Where do you get Peppermony skin?
So I don't know, sir.
Okay, in cirrhosis, you get usually in the upper limb.
Okay,
Have you heard of the term Campbell-D Morgan spot?
Yes, sir, but I do not know what it is.
Yeah, Campbell-D Morgan spot is just a red color spots that can be seen in normal individuals and also in cirrhosis patients.
Okay, sir.
If you want to check a spider navy, always check it in the sunlight, expose the patient and look for the spider navy. Okay?
Okay, sir.
Okay, right. Proceed.
So over the trunk, spider nevi, loss of pectoral and axillary hair, abdominal distension, dilated veins, purpura, loss of pubic hair, testicular atrophy present. There's no gynecomastia, caput medusae, and scratch marks. In the upper limbs.
Sorry, doctor. How will you differentiate caput medusa from umbilical hernia?
Sorry, sir?
Caput medusa from umbilical hernia. How will you differentiate caput medusa and umbilical hernia?
So in case of caput medusae, we can check the direction of the blood flow.
Okay.
So about
there is a closest differential diagnosis for this umbilical hernia is caput medusae.
Okay, sir.
So most of the patients, caput medusae is very rare, but your umbilical hernia is very, very common. Both are in the umbilicus only.
Okay, sir.
Okay. Okay, proceed.
So in the lower limbs, bilateral pedal edema present, so pitting tight from the ankles to the knees.
Okay.
There were no external markers of HIV infection or tuberculosis.
What are the external markers of tuberculosis?
So that can be scrofulloderma.
Okay.
Then cervical lymphadenopathy.
Okay.
That's also, I don't know the others.
Where do you get the flectin? Someone has told us flectin. So usually you get flectins in the limbus. Flectinular conjunctivitis can be there. Check for the choroidal. Choroidal tuberculosis, choroidal retinal retinitis can be there. Patient can have tinea versicolor. That is also an important thing. Okay, proceed.
So for systemic examination. So in the oral cavity, fetor hepaticus was present. Oral hygiene is adequate. There is no oral thrush, dental caries, pharyngeal deposits or gum hypertrophy. In the abdomen, on inspection, the abdomen is uniformly
What are the conditions where you can get a gum hypertrophy with ascites? Reason for gum hypertrophy?
So it could be due to phenytoin.
Okay, phenytoin, drug-induced can be a reason. Suppose this patient is a CKD patient, has gone in for a transplant, presents with gum hypertrophy. What do you think? Drug-induced only. What drug?
So
Any drugs
steroid.
used in the immunosuppressants? What immunosuppressant? Steroids can cause cyclosporin. Yes, cyclosporin can cause gum hypertrophy and also tacrolimus. Okay, proceed.
So on inspection, the abdomen was uniformly distended, flanks were full, the umbilicus was everted and appeared to be displaced towards the pubic symphysis. The skin over the abdomen was stretched and shiny, dilated veins over the abdomen and back present. No abnormal scars, sinuses, or pulsations. No divarication of recti, no visible gastric peristalsis seen. Hernial orifices.
If divarication of recti is present, what do you think?
So it could be due to tense ascites.
See, whenever you get a divarication of recti, that tells this patient has got a chronic ascites.
Okay, sir.
So, what are the other features of chronic ascites apart from divarication of recti?
There could be stretch marks seen.
Yes, stretch marks and divarication of recti gives us a clue. This ascites is not acute. This is there for quite a while. Okay, proceed.
Hernial orifices were free. Testicular atrophy is present. Palpation. First, superficial palpation. No warmth, no tenderness seen. On deep palpation.
Okay, if you have warmth, if you have tenderness, what do you think?
That could be due to an infection, hepatitis. Or,
hepatitis. In hepatitis, you get a diffuse tenderness or a focal tenderness?
So diffuse tenderness.
Hepatitis. Hepatitis, usually you get right hypochondrial tenderness. Okay. So patients, if you have warmth and tenderness, always rule out spontaneous bacterial peritonitis.
Okay, sir.
That spontaneous bacterial peritonitis can be because of bacterial infection or can be because of TB peritonitis as well.
Okay, sir.
Okay, if any patient who has got ascites, if they have fever, warmth, and tenderness, rule out SPP. That SPP should be your first differential diagnosis. Okay, proceed.
So the liver was felt as a non-tender, felt in the right hypochondrium, 10 centimeters below the right costal margin. It moves with respiration, firm, smooth, and rounded edge. The spleen and kidney were not palpable.
What is the liver span?
So approximately 10 centimeters. It should be less than 13 centimeters.
Okay, what is the normal liver span? Less than 13 centimeters.
Yes, sir.
So it's usually 11 to 15 centimeters.
Okay, sir.
So, okay, what was the inference from that?
So there's no hepatomegaly.
There's no hepatomegaly. Okay, did you do a tidal percussion?
No, sir.
What is tidal percussion?
So tidal percussion is done to differentiate between a lung pathology and a liver pathology. So in case of pleural effusion or consolidation, the liver can get displaced downwards. So on palpation, the liver border would be felt at a lower margin than usual. So in that case, we have to differentiate between hepatomegaly and liver displacement.
Okay. Okay. In the vitals, did you check for JVP?
No, sir.
What is the importance of JVP?
So JVP is usually raised in cardiac failure, and hepatojugular reflex can also be seen.
No, with respect to cirrhosis.
I don't know, sir.
What is cardiac cirrhosis?
Liver failures. Liver failure, cirrhosis secondary to cardiac failure.
So liver failure secondary to pulmonary hypertension.
Okay,
because if there is chronic congestion, the patient might have cardiac cirrhosis. So JVP will be elevated. Okay, so cardiac cirrhosis is also a differential diagnosis for cirrhosis. Okay, see, you don't get any history taking if you get this short case. Okay, so always look into JVP. JVP is equally important here. Okay, sir. Okay. Suppose this patient has a tender liver with ascites. What do you think?
So it could be due to any hepatic abscess.
Hepatic abscess. Okay.
Then
someone has told it's tricuspid regurgitation. That is because of your cardiac cirrhosis. Yeah, Budd-Chiari syndrome is very, very important. What is Budd-Chiari?
There is portal venous outflow obstruction.
Portal venous outflow obstruction or hepatic vein thrombosis?
So,
So Budd-Chiari syndrome is a hepatic vein thrombosis.
okay, sir.
Patient will have tender hepatomegaly with ascites. So if you see a patient, young patient with Budd-Chiari syndrome, always rule out any thrombus formation disorder like a thrombophilia. You
Okay,
need
sir.
to do APLA, you need to do SLE, those kind of homocystinemia. Those APLA workup and those workup has to be done. Okay.
Okay, sir.
So suppose you get a hepatomegaly with, can you get hepatomegaly in cirrhosis?
There's initially hepatomegaly before the liver shrinks.
Okay. If you get a hepatomegaly, it could be about 3 reasons: early cirrhosis, alcoholic hepatitis, hepatocellular carcinoma.
Okay, sir.
Okay. Okay. So the spleen is not palpable here.
No, sir.
Okay. Okay. I'll usually you get splenomegaly in cirrhosis.
No, sir.
No. When do you get splenomegaly in cirrhosis?
So it progresses to portal hypertension.
Okay. You see a patient today in the ward. The patient has got splenomegaly and cirrhosis. The next day you come to the ward, you check for that patient. There is no splenomegaly. What do you think has happened to the patient? You understand my question?
Yes, sir.
Yeah. If the patient has got any bleeding, a massive hematemesis will cause shrinkage of your spleen. So if there is no splenomegaly when you come next day, that means definitely the bleeding has happened. So always rule out UGAP. Okay.
Sir.
Okay. Proceed.
So the distance between the umbilicus and the xiphisternum was found to be 30 centimeters, and the distance between the umbilicus and the pubic symphysis was found to be 17 centimeters.
Will you check the abdominal girth daily?
Yes, sir.
Why?
So to make sure that there's no progression and to check for any improvement in his condition.
Yeah, whether whatever treatment you are giving, whether it is improving or not, or whether there is patient is progressing or not. Okay, response to the treatment. What is the significance of checking these measurements, whether from xiphisternum to umbilicus, umbilicus to pubic symphysis?
It's mainly to find out why the umbilicus has been displaced. So if the umbilicus has been displaced towards the pubic symphysis, it could be due to ascites or some mass in the epigastrium. And if the umbilicus has been displaced towards the pubic symphysis, it could be due to a distended bladder or some pelvic mass.
Okay, apart from this, any other measurement will you do? From umbilicus to right iliac fossa, left iliac fossa?
Yes, sir. From umbilicus to ASIS on both sides.
Why?
So then there can be displacement to either side if there's a mass on those respective sides.
Suppose if it is a ovarian cyst or a ovarian tumor, so it could umbilicus could be pushed. Okay,
yes,
what?
Sir.
Okay, proceed.
So on percussion, fluid thrill was present. And
was there any shifting dullness in your palpation?
No,
I mean,
sir,
your
this thing? So there was no shifting dullness.
Okay, can you get shifting dullness and fluid thrill together?
No, sir.
Why?
So in shifting dullness, the acidic fluid level should be it can be up to 1.5 liters. Once it goes beyond that, there'll be no space for the fluid to shift within the peritoneum.
So if there is fluid thrill, definitely there won't be shifting dullness. If there is shifting dullness, there won't be fluid thrill. Okay, accepted. Did you do a a deep palpation to check for splenomegaly?
No, sir.
Okay, in patients with ascites, tense ascites, to check for organomegaly is quite difficult.
Okay, sir.
But you need to do a deep palpation to find out whether there is a splenomegaly or not. If there is no spleen, also no need. No need to do too much of. Okay, doctor. Proceed. What is the importance of venous sum? If you get some sound over the liver, what do you think?
So it could be due to some tricuspid regurgitation or stenosis. And in case of portal hypertension, there will be collaterals formed between the umbilical veins and the falciform ligament. So
what
that can also be heard. The Crowellier-Baumgarten.
Crowellier-Baumgarten syndrome. Okay. So Crowellier-Baumgarten syndrome, your hepatocellular carcinoma can cause a venous sum. Tricuspid regurgitation can cause. Okay. Right. Proceed.
So on auscultation, normal bowel sounds were heard. No bruit, rub, or venous hum heard. The per-rectal
Okay.
examination was not done. All other systems were clinically normal.
Okay. So what is the importance of other system examination in a patient with cirrhosis?
So we have to examine the cardiovascular system for any cardiac pathology. So it could be a cardiac cirrhosis manifestation.
Okay. Cardiac cirrhosis could be a reason. Okay.
And
Because
then
of anemia, there could be a flow murmur or a hemic murmur that is possible. There could be a pansystolic murmur in the tricuspid region if you suspect a TR. Okay. In respiratory system?
So we have to rule out hepatopulmonary syndrome.
Hepatopulmonary syndrome. Okay. Anything else? Yeah, most important thing is a pleural effusion.
Okay, so
Why do you get a right-sided pleural effusion here?
So it could be there could be irritation of the pleural membrane following cirrhosis, and it can result in pleural effusion.
Okay,
And,
what is hydrothorax and pleural effusion? Both are one and the same. Hydrothorax is usually transudate.
Okay, sir.
Okay.
Okay, sir.
Okay. So what is the importance of examining the central nervous system?
So central nervous system, we have to rule out hepatic encephalopathy and any possible azotemia.
Okay.
The kidneys are also involved.
Fine. Okay. Proceed.
So a 45-year-old electrician, Mr. XYZ, came with complaints of abdominal distension for 3 weeks and yellowish discoloration of eyes for 1 week. There was also history of passage of clay-colored stools. On examination, he was found to have bilateral pitting pedal edema from the ankles to the knees, signs of liver cell failure and ascites. So he probably has a chronic decompensated liver disease without portal hypertension and hepatic encephalopathy.
Okay. So when you have a diagnosis writing session for your abdomen pain, the first most important thing is you are telling this is a chronic decompensated liver disease.
Yes, sir.
Why do you tell this is a decompensated liver disease?
So in this case, he's already progressed into liver failure and his condition has started deteriorating.
Okay. So the decompensation feature is patient should have jaundice, or patient should have ascites, or patient should have encephalopathy.
Okay,
If
sir.
these three, out of these three, any one is present, definitely this is a decompensated state. Accepted. What do you think is that? So first point is whether this is a chronic liver disease or not. So you're told it's a chronic liver disease. Someone asked me a question. What question is this? What was that question? Sorry, in the chat. Hydrothorax is transudate. That is the difference between hydrothorax and pleural effusion. Pleural effusion can be both transudate and exudate, but hydrothorax is transudate. Because of the diaphragmatic pores, the patient gets right-sided pleural effusion more than the left-sided pleural. The pores are somewhat more in the right-sided. That's why. Okay. Okay. So can you hear me?
Yes, sir.
Yeah. So this is a chronic decompensated liver disease. That point is accepted. What is the etiology?
So it could be due to alcoholic cirrhosis.
Okay, probably due to alcohol. Alcohol is the, so you need to write, this is a chronic decompensated liver disease, probably cirrhosis of the liver secondary due to alcohol. Okay, that etiology has to be mentioned with or without portal hypertension. So why do you tell this is the patient doesn't have a portal hypertension? What is the reason?
There's no splenomegaly in this patient.
Okay. What is the triad of portal hypertension?
Ascites, splenomegaly, and caput medusae.
Ascites, splenomegaly, and esophageal varices. That is the triad. Okay. So this patient has without portal hypertension accepted. Why do you think this patient has got hepatic encephalopathy?
Sir, in case of hepatic encephalopathy, he has no altered sleep pattern.
Okay.
And he is oriented, conscious,
okay.
and he's well aware of his surroundings.
Yes,
there's no asterixis as well.
Okay. So with or without portal hypertension, with or without hepatic encephalopathy, next with or without spontaneous bacterial peritonitis. You need to add that. With or without hepatorenal syndrome with or without hepatopulmonary syndrome, no signs of coagulopathy.
Okay, sir.
So if you write this kind of a diagnosis, so you are including all the complications of cirrhosis. So once again, I will repeat for the sake of others. So this patient is so and so has been diagnosed with chronic decompensated liver disease, cirrhosis of the liver, probably due to alcohol, with or without portal hypertension, with or without hepatic encephalopathy, with or without SVP, with or without HRS, with or without HPS, with or without coagulopathy. Okay, fine. What is the grading of hepatic encephalopathy? How do you grade?
So in case, so there are five. The grade goes from grades starts from grade 0 onwards. In grade 0, there is no obvious change in the patient's behavior. In grade 1, there will be mild changes and reduction in concentration.
Okay.
In grade
Hello.
Sorry, sir.
Yeah. Okay. So how do you investigate this patient?
So for investigations, we first carry out liver function tests. We'll be checking the bilirubin levels, the serum albumin and globulin levels, serum transaminases, and we do a coagulation profile as well. Then we do the hematological tests, which include a complete blood count, hemoglobin, electrolytes, blood ammonia.
Okay, based upon the LFT, can you tell this patient is a chronic alcoholic?
Yes, sir. In case of alcoholics, there'll be a rise in GGT levels.
Okay. How will be the ratio of SGOT, SGPT?
So,
Usually it will be 2:1.
okay, sir.
Okay. Okay. What is SAG ratio?
So it's the difference between the serum albumin and the acetic fluid albumin levels.
How do you do that? Simultaneously, or you will do one day before, one day after?
It's done simultaneously.
Simultaneously. Okay.
Okay.
What is SAG ratio?
So the normal
if the SAG
level,
ratio is more than 1.1, what does it denote?
so it means a patient can have, it could be due to portal hypertension.
Yeah, if it is more than
syndrome.
1.1, it is portal hypertension.
Yes, sir.
If it is less than 1.1, you need to think of exudative causes.
Yes, sir.
Like a tuberculosis. Okay. What is Madrick score? Or discriminant ratio?
I don't know, sir.
Okay. Go and read about what is discriminant ratio. It is used for alcoholic liver disease. Whether you need to start, if the score is more than 32, you need to start steroids. If it is less than 32, you can start pentoxifene.
Okay, sir.
Okay, it is based upon your prothrombin time. Prothrombin time is very, very important in patients with liver disease.
Okay, sir.
Okay, sorry. Okay, what is resistant ascites? Someone has asked me what is resistant ascites. Refractory ascites. Actually, the term is refractory ascites.
So the ascites recurs even after using diuretics to get
what is the dose?
Fluid. So I'm not aware of the dose.
Not responding to diuretics even with maximum amount. So 160 and 400. What is 400? What is 160? 160 is spironolactone or furosemide. 160 is furosemide. Spironolactone accepted. Okay. Okay. Apart from this, what other investigations will you do?
So imaging can also be done. You can do an ultrasound, a CT scan of the abdomen, and hepatic elastography. A liver biopsy can be conducted to check if there's any hepatocellular carcinoma.
Will you do viral markers for him?
Yes, sir. Viral markers need to be done to rule out hepatitis as well.
Okay, viral markers has to be done. Hepatitis B, hepatitis C, HIV has to be there. Apart from this, any upper GI endoscopy?
I don't know.
Usually, if you suspect a portal hypertension, if there is no portal hypertension, you need to do upper GI endoscopy. Okay, see, there could be something called as portal hypertensive gastropathy.
Okay, sir.
Portal hypertensive gastropathy is the earliest feature. The gastric mucosa will be angry looking and it will be congested. So you need to look in for a upper GI endoscopy that is to be done. Okay. Any other investigation
So
apart
we'll have
from
to
this?
acetic fluid examination.
Okay. Okay. In acetic fluid examination, if you suspect SPP, what will be the criteria? So if you suspect SPP, the total counts in the acetic fluid will be more than 250 with a positive blood culture. What kind of a growth will be there? So most commonly it will be E. coli followed by Klebsiella. Okay. Okay, fine, accepted. What other investigations would you like to do? Any other investigations?
No, sir.
Ultrasound abdomen. What is the importance of doing an ultrasound abdomen?
So to detect any organomegaly. So since the patient has tensitis.
Okay, okay, organomegaly. So what is the importance of doing a portal vein Doppler?
And that is to measure the portal venous pressures.
Okay. Can this be an NCPF? What is NCPF? Non-cirrhotic portal fibrosis. What is non-cirrhotic portal fibrosis? See, if a patient is a non-alcoholic, certain infections and thrombus can cause non-cirrhotic portal fibrosis. That also presents like this only with hepatomegaly. But there won't be ascites. Ascites is very rare in NCPF.
Okay, sir.
What is the point against extrahepatic portal venous obstruction in this patient? In extravenous portal hypertension, the patient will have massive splenomegaly.
Okay, sir.
Because of portal vein thrombosis and other extravascular, this thing, you get a massive spleen. Because of that, there will be pancytopenia.
Okay, sir.
Because of increased destruction. So
Okay,
you
sir.
are not having a splenomegaly. Therefore, this can't be a HPV.
Okay, sir.
Okay. Anything else? How do you treat this patient?
Since the patient has already progressed to liver failure, a liver transplant will have to be done. Apart
See,
from that,
don't write while you're presenting. Don't go for liver transplant straight away. Start with
sir.
your medical management.
Okay, sir.
Okay. So someone has told that RFT. Yes, RFT is very important. What is the complication with respect to RFT?
So hepatorenal syndrome.
What are the types of hepatorenal syndrome? There are two types, type 1 and type 2. Which is dangerous? Type 1 is dangerous. Type 1 is devastating. It increases. Okay. Type 2 is fairly okay. Okay. So how do you medically manage this patient?
So diuretics will be given to deal with the ascites.
Okay.
Then hepatotoxic drugs should be avoided and all vitamins should be supplemented.
Okay. Suppose if patient has got hepatic encephalopathy, will you supplement with high protein?
No, sir. We can't give high protein in that case.
You cannot give high protein. Okay. Okay. There are two patients. One patient with DCLD having diarrhea. Another patient with DCLD having constipation. Which patient you are happy? Which patient you are worried?
Constipation.
Why? Why? Why you are worried about constipation?
Bile pigments na வெளியவே போல encephalopathic போயிடுவாங்க.
Yeah. அதாவது என்ன ஆகும்னா கான்ஸ்டிபேஷன்ல பாக்டீரியல் டிரான்ஸ்லோகேஷன் வேகமா நடக்கும். பாக்டீரியல் டிரான்ஸ்லோகேஷன் வேகமா நடக்கிறப்போ பேஷண்ட்டுக்கு கட்ல என்ன ஆகும்? ஆர்கானிசம்ஸ் வந்து டெவலப் ஆயிட்டே இருக்கும். அந்த ஆர்கானிசம் will develop more amount of ammonia. That ammonia will cross the blood-brain barrier and be hepatotoxic. I mean, hepatic encephalopathy patient வரும். So that's why hydrogenically we are creating diarrhea. How? By giving laxatives. Laxative. Lactulose வந்து 15 to 45 ml வரைக்கும் ஒரு நாள் கொடுக்குறோம். At least 2 times he needs to go. Okay. Fine. You are giving lactulose, syrup lactulose. Why you want to give vitamin supplements? Which vitamin will you be supplementing?
So he will have to get vitamin B12 and thiamine supplements are very important since he is an alcoholic.
Vitamin K. Vitamin K is very important. 10 mg once daily for 3 days. Why?
To deal with any bleeding manifestations, especially
Liver
if he
is the
has an
most important
upper
thing for vitamin K dependent clotting factors like
2,
2,
7,
7,
2,
9.
9,
7,
10.
9, 10. Okay, for that you are giving vitamin K. Okay, anything else in the treatment? See, most of the alcoholics will have gastritis. So give them some proton pump inhibitor. Accepted. Why do you want to give a rifaximin?
Hepatic encephalopathy.
Okay. For the treatment or for the prophylaxis?
Prophylaxis.
Purila. Hello? Hello, for prophylaxis. Okay, accepted. What is the dose? 550 mg BD or 400 mg TDS? Accepted. What else will you be giving for the patient? Anything else? So vitamin K, rifaximin, neomycin usually we are not using because of the toxicity. That's why we are using the rifaximin. Okay. Pentoxifylline. Anything else? Suppose there is a massive bleeding, hematemesis is happening. How do you treat that patient?
So we have to look, find out the location of the bleed to begin with.
Okay.
So if it's due to varices, somatostatin analogs and octreotide can be given.
Okay, octreotide can be given. Whenever the patient is having an acute blood loss, always check the vitals, then replace them with blood. Because blood contains more amount of plasma proteins and this thing. So you're replacing with blood, starting octreotide. Anything else? Any other drug which constricts the vessels, Bank-like constriction? Banding, sclerotherapy, everything is accepted. Any other drug that can be given? Propranolol is not used in acute setup. Propranolol is used to reduce the portal pressure and to prevent the future episodes. Yeah, terlipressin. Terlipressin should be used. Okay, since taken Blackmore, yeah, those and all, it's not nowadays used. Terlipressin and octreotide is important. Remember one point, most of the patients with alcoholism, octreotide will work only in portal hypertension cause of bleeding, that is esophageal varices, but not in your medullary veins or any other coagulopathy. Only in your portal hypertension, octreotide works. Okay, octreotide accepted, this thing accepted. Any other drug will you give? What is Lola? L-ornithine, L-aspartate. It is used in hepatic encephalopathy. Okay. Anything else? Any other drugs can be used? Carbos. Okay, suppose this patient is a non-alcoholic fatty liver disease. What other drugs can be used?
So statins can be given to reduce cholesterol
Statins can be
levels.
given. Okay, anything else? Any vitamins? Vitamin B1, vitamin E. Vitamin E plays a role as an antioxidant. Okay. Okay, suppose this patient has suspecting spontaneous bacterial peritonitis. How will you treat that patient?
So he'll need IV antibiotics.
What antibiotic?
Broad spectrum antibiotics,
Like?
third generation cephalosporins.
With cefotaxime or ceftriaxone?
No, sir.
Cefotaxime is the drug of choice
Okay, sir.
because it is not metabolized in the liver. So
Okay, sir.
don't use ceftriaxone. Give cefotaxime. Cefotaxime 1 gram IV TDS is needed. Okay. Then how much? Whenever you are suspecting a spontaneous bacterial peritonitis, send more fluid, ascitic fluid for analysis for culture. Don't send just 5-10 ml. Send 50 to 100 ml.
Okay,
Even
sir.
if you send 500 liter, then only it will be centrifuged and you can extract the organism.
Okay, sir.
Okay, what is spontaneous bacterial peritonitis versus secondary bacterial peritonitis? Any differences there? Monoorganism. Okay, single organism. Fine. Your secondary bacterial is secondary to other cause. Like what? Say if you are doing a paracentesis and it is not sterile and you are injecting something else, it creates a problem. That is secondary bacterial peritonitis. Because of bacterial translocation, if the ascites gets infected, it's spontaneous bacterial peritonitis. Okay. What do you think is the reason for the ascites? What is the theory behind ascites formation?
So it can be due to reduced albumin levels. So the
Okay.
fluid oncotic pressure goes down
Okay.
and there is increased translation
What happens
of
to the
fluid.
splanchnic circulation?
On the splanchnic vasodilation.
Vasodilation. Okay. How do you classify portal hypertension?
It can be pre-sinusoidal, pre-hepatic, hepatic, and post-hepatic.
Okay.
And hepatic causes can be classified as pre-sinusoidal, sinusoidal, and post-sinusoidal.
Okay. 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 When do you send the patient for hepatic transplantation? What is MELD score? MELD.
So,
Okay. Where do you score for child per classification?
so it's to determine the outcome of liver cell failure.
What are the parameters used in child per classification?
So,
Okay, read about that child per classification, read about MELD score. Those areas questions might come.
Okay, sir.
Okay, read about the matrix score. So at discriminant ratio, read about the causes, etiology of cirrhosis, read about cirrhosis types, read about pulmonary portal hypertension causes. What are the causes of exudative ascites, transudative ascites? Okay, if you do a ascites tapping, it is very bloody. What do you think?
So it could be due to tuberculosis.
Tuberculosis.
Sorry, sir, malignant ascites.
Malignant ascites. Okay. Can pancreatitis cause ascites?
Yes, sir.
How it will be?
It will be cloudy.
Cloudy. It can be hemorrhagic.
Okay.
Okay. If you just do a ascites tap, it is white in color. What do you think?
It could be due to excess chyle.
Excess chyle. Okay. Fine. Accepted. What is Meek syndrome?
It's ascites secondary to certain ovarian tumors, such as granulosa tumors and Pica cell tumors.
Okay. Fine. So read about those theories behind your ascites. Usually abdomen is quite easy to pass. Okay, you did well. Most of them are doing very well. Read about what are the scars that will be seen in liver transplant, renal transplant. Okay, if you do a liver transplant, where do you keep the liver? Well, if a patient has renal transplant, where does the new kidney is placed?
It's placed in the pelvic cavity.
Usually in the right iliac fossa.
Okay,
where do you get inverted bend scar appearance? Okay, find out what is the scar in liver transplant, what is the scar that is seen in renal transplant. Okay. Someone asked me about the spider navy in internal organs. Usually internal organs you need not worry about. Usually it's seen in the SPC territory, in the trunk, nape of the neck, the SPC territory. That is enough sunlight. You need to expose the patient and look into there. Okay. Any other this thing? Complications you expect from this patient? Suppose this patient lands with a coagulopathy. How do you manage the patient with coagulopathy? Hello. FFP. Yes. Fresh frozen plasma is important. Transfuse with FFP. Usually, if a patient sets with coagulopathy and DIC, it's very difficult for us to get through the patient. Read about the dose of the terlipressin. How do LOLA acts, L-ornithine, L-aspartate acts in patients with this thing. Sometimes you can get hepatosplenomegaly without ascites. What are the causes for massive splenomegaly?
So it can be due to CML, chronic myeloid leukemia, chronic leukocytic leukemia.
See, most of the examiners are very fond of asking about CML. So read about what is Philadelphia chromosome, what is the BCR-ABL translocation, what is tyrosine kinase inhibitor. Okay.
Okay, sir.
See, in ascites precox, usually everyone develops period edema followed by ascites. But in ascites precox, you develop ascites followed by period edema. Usually it's in constrictive pericarditis.
Okay, sir.
Okay. So read about CML, imatinib, what is nilotinib, what is dasatinib, how do you treat patients with, how do you investigate patients with CML, what is FISH? So fluorescent in situ hybridization technique, they will be asking about the CML. CML is very, very fond. Okay, if you suspect a hematological disease, which important clinical sign you expect? Clinical sign. Check for sternal tenderness.
Okay, sir.
If you see anemia with lymph nodes, always look for sternal tenderness. Sternal tenderness is there means you are leading with a hematological malignancy.
Okay, sir.
Okay. Apart from CML, any other causes for massive splenomegaly?
It could be due to malaria and leptospirosis.
Usually in malaria, you won't get in acute malaria. You get it in chronic malaria because of tropical splenomegaly syndrome.
Okay, sir.
Okay, don't immediately rush to tell it is Kala Azar. We stay in Tamil Nadu. Here Kala Azar is very rare. So keep Kala Azar at the last. So tell CML, chronic malaria, myelofibrosis, storage disorders. Then you can go for the extrapulmonary portal venous obstruction, extrahepatic portal venous obstruction. Then you can tell chronic Kala Azar. Okay. So you can have patients with hepatosplenomegaly, hepatomegaly. So cirrhosis is quite easy. Any other questions? You did well, Ma. All the best for your exams. When is your exam?
So mine is on the 22nd of April.
22nd of April. You are actually from?
Tagore Medical College.
Oh, Arunagiri sir student, huh?
Yes, sir.
Okay, okay. So make sure you observe the patient. Observation is very, very, very important in in medicine. Importance of asking urinary tract symptoms in liver disease. Usually patients with, you need to check about oliguria. Patients who are going in for hepatorenal syndrome, they will have oliguria. So ask about oliguria, reduced urinary output. Sometimes there could be coexisting infection as well. Okay. Your Castle's method, Nixon's method and all, you need to examine the patient in such a way that you do the alternative examination technique. Okay, that is you have to do with this thing. Burning, micturition and vomiting, why should we ask? Regarding DCLD. See, in patients with cirrhosis, there could be coexisting infection. Usually ask about reduced urinary output. Burning, vomiting can be because of any infection or because of gastropathy. Portal hypertensive gastropathy or chronic alcoholism can cause coexisting H. pylori infection and other related disorders that can cause vomiting. At times, certain drugs also can cause vomiting. So don't go into specific intricacies of such symptoms. So that is not that much this thing. Sir, why is ADA is raised in tuberculosis? Why is ADA is raised in tuberculosis? What is ADA?
Adenosine deaminase.
Adenosine deaminase is why it is raised in tuberculosis. Any idea?
No, sir.
Anyone, any audience? Why is ADA is elevated? See, in ADA, that ADA is because of that cycle. The thing is, in pleural effusion, the ADA is quite specific for TB. So if the ADA is elevated in more than 40, usually it depends upon if it is 24 also, we take as a guaranteed that the patient has got tuberculosis. But in ascites and your CSF, ADA is not that much value. So in pleural effusion only, we think of ADA. Okay. So at times tuberculosis can be kept as a case in patients. So if you get only ascites, nothing else is there. Always think of tuberculosis as well.
Okay, sir.
Okay. Any other thing is with respect to this thing, DCLD, almost undergraduate level, this is enough. Any other doubts? Okay, all the best for your exams.
Thank you, sir. Thank you so much for this amazing session, sir.
Okay.
We have completed our medicine session today.
Okay.
From tomorrow, we will get back to the pediatric sessions. Tomorrow, we will discuss about the cyanotic heart disease, tetralogy of Fallot. Case discussion at 9 p.m. Note the timing again. Case discussion at 9 p.m. Thank you so much for joining. Thank you, everyone.
Thank you.